Again, this is, you're going to see a couple of these little pictures here in terms of, the progression of whatever form of cardiovascular disease I'm talking about and how it relates to sleep apnea. So increased myocardial demands, intermittent hypoxia, causing effects on your afterload, negative interthoracic pressures, which we already talked about, increasing preload and afterload, catecholamines and cytokines being involved here, IL-6, IL-8, TNF-alpha, those are sort of the big ones, and then the sympathetic, increased sympathetic outflow. Now that was in obstructive apnea. This is in central apnea. You get increases in your LV filling pressures, greater instability, electrical instability, which the previous this previous speaker was talking about, prolonged circulation times, increased chemoreflexes. So you have chemoreceptors in the carotid arteries, and you also have chemoreceptors in your brainstem. And the ones in the carotid arteries usually sense changes in your partial pressure of oxygen, and the one in the brainstem senses changes in your partial pressure of CO2. And so they become more sensitive because you're resetting those levels because you're swinging really high and swinging really low. You also get pulmonary vascular congestion and a higher resting sympathetic drive. So you have a higher level of your epinephrine, norepinephrine sort of circulating at rest. So we see that OSA is associated with altered cardiac structure and function, which may be reversible with CPAP. And so there have been some CPAP studies. So after 3 months of using CPAP, they see improved abnormal diastolic filling pressures and function. We also see improved left ventricular ejection fraction, and people report quality of life is better, after they've been on CPAP. So we're starting to see that those remodeling changes that were happening in the heart, you put them on CPAP, and they actually go away. They get better. Increases or decreases myocardial irritability and the risk for arrhythmia. It is not uncommon that I'll do a study at nighttime, and they'll have an arrhythmia during the study, and then I put them on CPAP, or then maybe they just have lots of PVCs, and I put them on CPAP. Boom, all the PVCs go away. I'll tell you a more serious story. So there was a gentleman, I don't know, he was about a 50-year-old gentleman, sort of your classic, overweight gentleman coming in, and he had canceled to see me as an initial consult 11 times. And I didn't even know the guy. I didn't know the guy at all, and it's just that he kept rescheduling, which I give him credit for, 11 times. So on the 12th time, I saw the guy. And I said, he gives me his story, and I'm like, very high probability of sleep apnea. He works as a chef. I don't know where, and I'm not going to tell you. So he works as a chef and can't get here. His hours are crazy. He's a big wig chef guy, and so finally he comes into the lab. I don't know. He has 120 events an hour. I mean, it was god awful. It was terrible, right? And during the study, he had pauses. He had, these, as you saw on your last speaker, those 2-3 second pauses. So I started counting them up, and he had like 2 or 3 or 4 of them. And then all of a sudden, at 4:31 in the morning, he had a 15-second pause. 15-second pause. All right, I started to get nervous. 15-second pause. Oh my gosh, he's going to have a heart attack here. So I call the guy and, get him back in for a CPAP right away. And he does. He comes back right away, and, it's the best thing to slice bread now for him, by the way. But I put a call into my cardiologist, and I said, does he need a pacemaker? And she said, no. She said, because he's on CPAP, and I saw that after he went on CPAP, it was completely normal. His heart rate was completely normal. There were no pauses. He had completely normal rhythm. And she said, just do a Holter monitor in a month or so, see how he does with that, and just sort of follow him. But he's on definitive therapy. He doesn't need a pacemaker. I've also had people who walk out of my office at 8 o'clock in the morning who have had type 1 and type 2, Wenckebach, who I have immediately sent over, and they got their pacemaker the same day. So this guy had essentially normal rhythm, just that really big pause, and she said, no pacemaker for him. So I don't know if that's truly the right answer. I'm obviously following him, but so far so good, you know, in this gentleman. So anyway, let's get back to heart failure. Okay, so it's essentially we see that it gets better with CPAP. Now, this is in the group of obstructive sleep apnea patients. They tend to see improvement in their heart function and muscles, but we're going to talk a little bit about the central patients in a minute. So this is a new study, and this just sort of corroborates what I've been talking about. 120 patients were studied, and this was March of this year. 120 patients were studied, and 40 of them had moderate to severe sleep apnea with AHI defined as greater than 15. 40 patients had hypertension alone, and 40 patients were normal healthy subjects. And they followed them on CPAP, these ones with moderate to severe sleep apnea, for 26 weeks. And they saw that compared to the hypertensive group and compared to the healthy volunteers, there was a decreased posterior wall thickness, improved LV ejection fraction by, I think, around 5%. Systolic velocity was improved, their stroke volume, and diastolic left ventricular impairment was less. So they followed them for 3 months and a year. So it's important for these people to stay on therapy. It's important for them to use it every day, every night. I get that question a lot too. Do I need to do it? Can I take a weekend off? No, you really can. You really can. Okay, so the effect of CPAP on central sleep apnea in heart failure is not as well understood. The CANPAP study, which was in 2005, actually I think was ended early because they saw an increased risk of death. So they had people on CPAP, but there were some problems with that study, and I'm not going to go into all of that. But I think that it's not really clear yet if CPAP is the best thing, or BiPAP, or some form of positive airway pressure is the best thing for your central sleep apnea patients. We do know that cardiac resynchronization, and again, the last speaker did mention that a little bit, where you do some biventricular pacing, actually improves central sleep apnea and Cheyne-Stokes respiration in those patients. Okay, so let's switch over to stroke a little bit. There's, again, high prevalence, 40 to 70% of patients have either obstructive or central apnea. I will say that all of the studies that are done in stroke patients are biased right from the get-go. And the reason why is because patients who have had a stroke who don't survive, we can't study. We can only study patients who have survived. And so all the studies that have been done are on stroke survivors or patients in rehabs who have had a stroke. And we find that there's a high risk. We find that sleep-disordered breathing is a risk for stroke, and we find that stroke is a risk factor for sleep-disordered breathing. So it's both bidirectional. And again, this little picture, you know, what is seen in the progression of stroke and sleep apnea. You get your blood pressure fluctuations. You have your prothrombotic, so clotting factors. You have pro-inflammatory mediators. You have altered cerebral regulation and blood flow, hypoxia, accelerated atherogenesis, and impaired endothelial function. CPAP has been shown to normalize cerebral blood flow after 4 to 6 weeks. Hypoxic events predict a poor stroke recovery, and there is improved long-term survival in CPAP-compliant post-stroke patients. But the problem is that sometimes stroke patients can't tolerate it very well. I have a gentleman who had a stroke. He was living fine at home, doing well, excuse me. And he had a stroke and lost his whole left side. And he comes in, it actually has a little bit left, but he comes in and he's really hobbling along to get in. And he lives at home with his wife and daughter or whatever, who are not very, unfortunately, helpful. And he can't use his left arm. He can't get his CPAP on. He can't do it. And I ask him, do you have help at home? Well, and he doesn't, for some reason his home situation is not good. He's not using it. He's not using it, and actually he's on oxygen now. I mean, the second best is oxygen, because he just could not get to the point where he could use it regularly.